Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, 5-year outcomes of a randomized phase 3 trial comparing adjuvant chemotherapy with S1 versus surgery alone in stages 2 and 3 gastric cancer, the ACTS-GC study, written by Mitsuru Sasako and colleagues. My name is Robert Mayer, and I am the Stephen B. Kay Family Professor of Medicine at the Dana-Farber Cancer Institute and the Harvard Medical School in Boston, Massachusetts. My oncology specialty is medical oncology. With a podcast, Adjuvant Treatment for Gastric Cancer, the story continues to evolve. Gastric cancer in 2011 remains a formidable problem, both in the United States, where it represents the 14th most common cause of cancer-related death, and, more importantly, worldwide, where it is the second leading cause of cancer-related mortality. The disease occurs most commonly in Japan, Korea, and China, less frequently in Europe and South America, and far less often in North America, Australia, and New Zealand. The likelihood of surgical cure for patients with gastric cancer appears to differ by geographic location, possibly due to biological variations in the disease, but more likely the result of technical differences in the operative procedure. There is general agreement that the presence of tumor involvement at the resection margin leads to an extremely poor prognosis. Debate persists about the optimal extent of lymph node dissection to be performed at the time of gastric cancer surgery. Such dissections include the D1 procedure, including the removal of the involved part of the stomach, perigastric lymph nodes, and the greater and lesser omentum, and a D2 procedure, which also includes the removal of common hepatic, splenic, and celiac lymph nodes. Consensus now exists that an incomplete resection of perigastric lymph nodes, a so-called D0 resection, is inadequate, while the removal of the spleen and pancreas as part of a D2 resection increases surgical morbidity without providing any survival advantage. A D2 resection represents standard surgical care in such high-incidence regions as Japan and Korea, whereas D1 procedures are more commonly performed in Europe and North America. At least 5 randomized studies have compared D1 and D2 dissections with a meta-analysis based primarily on 5 years of follow-up, showing significantly increased mortality after a D2 resection without any enhanced survival benefit. However, the results of the most widely known of these efforts, which enrolled 711 patients, the so-called Dutch gastric cancer trial, in which an experienced Japanese surgeon was personally involved at the time of an operation to assure that an appropriate D2 resection was carried out, is now showing a decrease in local regional recurrences and a statistically significant reduction in gastric cancer deaths, with this difference only becoming apparent after 10 years of follow-up. Adjuvant, neoadjuvant, and perioperative chemotherapy, as well as chemoradiation therapy, have all been examined in patients with resectable gastric cancer, but rarely in association with D2 resections. A meta-analysis of 17 randomized trials assessing the benefit of adjuvant chemotherapy concluded that adjuvant treatment results in an 18% reduction in deaths from gastric cancer, with the median survival time being extended from 4.9 years to 7.8 years. Perioperative chemotherapy, including cisplatin and infusional 5-fluorouracil, has been reported to increase the 5-year overall likelihood of survival when compared to surgery alone from 23% to 36% in both British and French studies. Less than half the patients in these two studies had undergone a D2 resection. In North America, adjuvant efforts in gastric cancer have focused on the use of post-operative chemoradiation therapy. In the intergroup 0116 trial, 557 patients were randomized to receive radiation therapy accompanied by 5-fluorouracil and leucovorin. The post-operative treatment enhanced the median survival from 26 months to 35 months, due in large part to a reduction in local recurrences in the treatment cohort. While it was recommended that study patients receive a D2 resection, such operations were only performed in 10% of registrants. More than half the patients had a D0 resection, suboptimal surgery in everyone's estimation, leading to the strong likelihood that the reduction in local recurrences in the patients allocated to receive chemoradiation therapy might actually reflect the radiation atoning for inadequate surgery. Post-operative chemoradiation therapy presently remains the standard of care in North America. With the growing appreciation that a D2 resection quite likely represents the optimal surgical procedure for gastric cancer, and that chemotherapy or chemoradiation therapy is beneficial for patients who have undergone less than a D2 resection, the question remains as to the value of adjuvant treatment in individuals who have undergone a D2 operation. This issue has been addressed in the JCO paper by Sasako and colleagues, which is the subject of this podcast. In this study, more than 1,000 Japanese patients with stages 2, 3A, and 3B gastric cancers were randomized to receive 1 year of an oral fluoropyrimidine or observation alone. The oral fluoropyrimidine they utilized was S1, a compound consisting of tegafor, a prodrug of 5-FU, gemerseril, which inhibits 5-FU catabolism, and oterosyl potassium, which protects against 5-FU-induced diarrhea. Dr. Sasako and associates accrued their patients between 2001 and 2004. After a median follow-up time of approximately 3 years, S1 therapy resulted in a 32% reduction in cancer deaths, with a 3-year overall survival in the S1 group being 80.1% compared with 70.1% in the surgery-only group. These results appeared in the New England Journal of Medicine in 2007. Dr. Sasako and colleagues have now released the 5-year follow-up data for this study, which are being published in the Journal of Clinical Oncology. The 10% survival advantage and 33% reduction in cancer deaths for treatment with S1 have persisted, with 71.7% of the treated patients remaining alive compared to a 61.1% survival rate for the controls. Interestingly, the treatment benefit was greatest in patients with stage 2 disease, a 49% reduction in death, intermediate in patients with stage 3 disease, a 29% reduction in death, and less impressive in patients with stage 3B disease, a 21% reduction in death. in contrast to the 29% local and 72% regional recurrence rates reported by North American investigators in the observation arm of the intergroup 0116 study. The local and regional recurrence rates in the surgery-only arm of the Japanese adjuvant trial were only 3.2% and 29.1% respectively. These encouraging data raise several issues. First, there clearly is a wide range in 5 years surgical survival outcomes for patients with gastric cancer, ranging from 60% in the Japanese series of Sasako to 45% in the Dutch gastric cancer trial to 24% in the North American intergroup 0116 experience. This pattern, along with the mature results of the Dutch surgical study, appears to support the superiority of the D2 surgical approach. Furthermore, the variability in operative outcome also signifies the importance of clinical experience and caseload on the part of hospital and surgeon in making technical judgments and providing postoperative support. Also, in view of these D2 results from Japan and the Netherlands, and the far lower local regional recurrence rate when compared to North American results, the need for postoperative radiation therapy following an optimal surgical procedure merits reconsideration. Second, while Sasako and colleagues utilized S1 as the fluoropyrimidine in this adjuvant clinical trial, there is no indication that S1 is any more effective than 5-FU or capecitabine and may be harder to dose worldwide because Asian and white individuals have different rates of activation of Tegafor to 5-FU because of variable concentrations of the needed hepatic cytochrome enzyme. Furthermore, a randomized comparison of an S1 cisplatin combination to an infusional 5-FU cisplatin combination in non-Asian gastric cancer patients failed to show any therapeutic advantage for S1 over 5-FU. Third, the observation that the treatment effect of S1 in the Japanese adjuvant trial is greatest in lower stage patients is intriguing. It raises the question of whether adding cisplatin or a taxane to a fluoropyrimidine, particularly in patients with stages 3A and 3B disease, might not enhance outcome. Japanese investigators are currently exploring the value of neoadjuvant S1 cisplatin combination. Finally, the results of the large, well-analyzed trial conducted by Sasako and Associates provide further support for the routine use of adjuvant, neoadjuvant, or perioperative chemotherapy for patients with resectable gastric cancer. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.